Dr. Tuttle is a professor of medicine in the nephrology division at the University of Washington, an executive director for research at Providence Healthcare, and co-principal investigator of the Institution of Translational Health Sciences. She's an investigator in the Kidney Research Institute and oversees interests of the 5-state WWAMI region to the ITHs. She also directs the Northwest Participant Clinical Interactions. Her major research is in the area of clinical and translational science and precise medicine strategies to tackle diabetic kidney disease, chronic kidney disease, diabetes, and hypertension. Dr. Tuttle, this is all yours.
Hello, everyone. Let me share my screen. Just want to check and make sure that you can see my screen.
Yes, we can.
Dr. Tuttle, you're good. We can see you and see your screen and hear you. Thank you.
Good. Okay. Well, thank you. It's really a pleasure to be joining you from across the world this morning to talk to you about this very important problem of diabetic kidney disease, but where we certainly do have challenges, but we've had major progress, and I think there are possibilities to greatly improve lives as a result of this progress. These are my disclosures. They're all related to therapeutics for diabetes and kidney disease. Most are research grants and other support paid to my institution. So my objectives today will be to discuss the current approaches for chronic kidney disease and diabetes, to recognize use of newer therapeutic agents for chronic kidney disease based on the recent trials, and then to discuss advancing therapeutics in chronic kidney disease by more precise phenotyping. So I'm going to start with a centering point about the other pandemic, which is the pandemic of diabetes, well known to this audience, and of course the topic of the entire meeting. But when we look at the worldwide burden, in 2019, we estimated there are 463 million people living with diabetes. But unfortunately, by 2045, this number is only going to grow substantially to some 700 million. And in the regions here, mostly south of the equator in the green box, all will incur more than a 50% increase. And in some regions, such as sub-Saharan Africa, more than 100%. And even here in India, it's projected to increase 74%. So while our aspirational goal is to prevent and cure diabetes, the reality is that for the foreseeable future, and really for our lifetimes, we are going to be taking care of more and more people living with diabetes. Living with diabetes means living with diabetic complications, and I'd like to make the case that diabetic kidney disease is one of the most serious matters. It's still very common in both type 1 and type 2 diabetes, about 30% in type 1 and 40% in type 2. And diabetes is now responsible for half of all cases of chronic kidney disease and kidney failure or end-stage kidney disease worldwide. But what we know is that the prevalence in the end-stage kidney disease population is more than half. It's 66 to 86%, depending on age and race. And this is largely related to the fact that people with kidney failure or end-stage kidney disease may have a different form of kidney disease and also have diabetes, but especially in the transplant population, we give people post-transplant diabetes by medications such as glucocorticoids and calcineurin inhibitors. And even from the standpoint of cardiovascular risk reduction, chronic kidney disease is a major amplifier of CVD risk. And in fact, almost all of the excess diabetes-associated cardiovascular risk occurs in those with albuminuria, low GFR, or both. So this is a very important group to target for cardiovascular risk reduction strategies. Speaking of risks, it's also worthy to spend a few moments thinking about what are the risks of diabetic kidney disease, also known as CKD and diabetes. Well, truthfully, only 10% progress to kidney failure or end-stage kidney disease. But that's not because they're healthy. It's because they're dying of other causes without reaching kidney failure. About half the deaths are cardiovascular, both atherosclerotic events and heart failure events. But the second leading cause is infection. Historically, pneumonia and sepsis, and with the current pandemic of COVID-19, where people with diabetes and kidney disease are even more susceptible to the infection and severe complications, one can only imagine the potential impact on mortality in this population. So now that we've rung the alarm bell about the seriousness of the problem, what can we do about it? Well, until recently, the only agents specifically indicated for the treatment of kidney disease and diabetes were the renin-angiotensin system inhibitors. These were the last two trials until recently shown to reduce risk of progression to kidney failure. And these were the ARB trials of losartan in renal and irbesartan in ID&T. And while these were celebrated at the time, notice that the relative risk reductions were modest, some 16% in losartan with losartan and 20% with irbesartan. And although these curves are drawn on slightly different scales, the absolute residual risk at 48 months was exactly the same in both trials, some 40%. So we had enormous residual risk. Moreover, at least in the United States, we haven't done a very good job of even applying these therapies. This is real-world data from two large U.S. healthcare systems, the Providence healthcare system where I work and UCLA Health, showing that over time, since those trials were published, there was an uptick in the use of ACE inhibitors and angiotensin receptor blockers. But overall in the CKD population, it was still only 15%. And if we look at the population who also had diabetes and hypertension, perhaps the hardest indication to use these agents, we still only use them in 25% of patients. At the same time, we were increasing our use of proton pump inhibitors and nonsteroidal anti-inflammatory drugs, potential nephrotoxins. And in fact, in the most recent time period through 2017, a third of people were getting a potential nephrotoxin, and only 25% or less were getting kidney protective agents. So it's really no wonder that the outcomes in this population have been so poor. We've had modestly effective therapies, we're underutilizing them, and at the same time, we're doing harmful things. Now, the lack of progress in terms of new therapies in this area has really not been for lack of trying. This is a representative, but certainly not all-inclusive list of many agents that have been under study for diabetic kidney disease, along with the current status. And while some completed without delivering new therapies, this was not always due to clinical or scientific reasons. In some cases, they were business and regulatory decisions where a sponsor simply walked away from an effective therapy because they decided that they weren't going to invest in that area, which is unfortunate. But in recent years, we've really had some major breakthroughs, particularly the new anti-hyperglycemic agents, endothelin receptor antagonists, and Phenerenone. And today I will be talking about the topics in the purple boxes. With regard to SGLT2, I'm only going to give a very brief introduction because that'll be the topic of the next presentation. But just to give a preview of how we got to these agents, it really came from the cardiovascular outcome trials that were mandated by the US FDA to show safety of these agents after approval for glucose lowering. And not only have these agents been shown to be safe, they've been shown to be very effective to reduce major adverse cardiovascular events, both heart failure and atherosclerotic events. And two agents in the class, empagliflozin in the EMPA-REG trial and dapagliflozin in the DAPA heart failure trial, reduced cardiovascular death. But importantly, the major secondary outcomes were kidney disease outcomes. And across the class, they also have reduced risk of albuminuria, GFR decline, and kidney failure. And I do want to emphasize that both the kidney and the cardiovascular benefits are present in this very high-risk population of patients with type 2 diabetes and CKD. And you'll hear much more about this in the next presentation. But this is just a sneak preview because this really is the major class that has delivered in terms of improving outcomes. But the other major class are the GLP-1 receptor agonists that were studied in exactly the same way. And similar to the SGLT2s, they've been shown to not only be safe, but to reduce atherosclerotic disease risk. And two agents in the class, liraglutide in LEADER and semaglutide in PIONEER 6, were shown to reduce cardiovascular death. But again, the major secondary outcomes were kidney disease outcomes. And across the board, in the cardiovascular outcome trials, these agents decreased macroalbuminuria as well as GFR decline. And uniquely in this class of agents, they've been studied in patients with very low GFR, with dulaglutide down to a GFR of 15. And the kidney benefits to preserve function are present even in advanced CKD. So this is very important because we do need treatments not only for glucose lowering, but preservation of kidney function, even in patients with advanced kidney disease. And again, both the cardiovascular and kidney benefits are present even in this high-risk population of people with type 2 diabetes and CKD. This is from a meta-analysis of the CV outcome trials that was recently published, showing the composite kidney outcome, including albuminuria, and without albuminuria, it's slightly less. But remember, selecting patients for cardiovascular risk selects a population who have either no kidney disease or early stage kidney disease. So the outcome we can detect in the early time period of the trials is really reduction in albuminuria. And this has now been replicated in the Amplitude O study, another GLP-1. And actually just this week, in fact, I think yesterday, a new meta-analysis came out adding Amplitude and basically just further reinforced the data here and did not change the risk estimates. But this trial, Award 7, was conducted in patients with the lowest GFR to date. Note that the mean GFR in the patients in Award 7 was just 35. And this was a glycemic lowering study comparing insulin to a higher or lower dose dulaglutide. But the major secondary outcome were kidney disease outcomes. And you can see that in the insulin-treated group, there was an expected decline in GFR over 1 year, as we would expect in this type of population. But GFR stabilized in the 2 dulaglutide groups. And these are just the data shown at 26 and 52 weeks as bar graphs. Expected significant loss of kidney function in the insulin-treated group, but this was essentially abrogated in either dose of dulaglutide, with either dose of dulaglutide, such that there was no significant decline over 1 year and highly significant between group differences between insulin and either dose of dulaglutide. A major exploratory but pre-specified outcome were kidney disease endpoints, such as those we would use in a kidney disease outcomes trial, 40% GFR decline or kidney failure requiring dialysis or transplantation. As you can see, these risks overall were reduced by more than half. And in the group that had macroalbuminuria, which was about half of the patients, in a time to event analysis, the hazards ratio was 0.25, so a risk reduction of 75%. How might this be happening? We think these work quite differently than the SGLT2 inhibitors. GLP-1 receptor agonists bind the GLP-1 receptor with high affinity. And outside of the pancreas, particularly in the kidney, there are anti-inflammatory effects mediated through an increase in intracellular cyclic AMP that blocks oxidative stress, apoptotic signaling, as well as pro-inflammatory and pro-fibrotic transcription. And GLP-1 receptors are present on intrinsic kidney cells, consistently in the endothelium and variably in proximal tubular cells. But remember that not all cells in the kidney are intrinsic cells. There's quite a profound inflammatory infiltrate, particularly in the tubular interstitium, represented in this cartoon here from a paper in Nature Reviews. And these infiltrating cells also contain GLP-1 receptors and really drive the inflammatory response. So in preclinical models, when we give a GLP-1 receptor agonist, this inflammatory infiltrate is markedly reduced, along with a reduction in the number of immune cells. So we think that in addition to glycemic lowering, that these agents act by an anti-inflammatory mechanism. These data from the cardiovascular outcome trials, Award 7, and the preclinical data provided the rationale for the first dedicated kidney disease outcomes trial called FLOW, which is now testing semaglutide versus placebo in a classic population with type 2 diabetes and CKD on the background of an ACE inhibitor or an ARB. And despite COVID-19, we fully enrolled this trial on time at the end of March. Retention is excellent. And we're expected to go at least another 2 to 3 years with this trial. So stay tuned, and this will hopefully show us whether or not a GLP-1 will specifically and intentionally reduce kidney disease outcomes in this population. So with regard to the new glucose-lowering agents, I mentioned at the beginning of the talk, in the real world, the uptake of ACE inhibitors and ARBs has been low. This paper was just published several weeks ago online in Diabetes Care, looking at the newer glucose-lowering agents, SGLT2s represented in yellow and GLP-1s in orange. in relation to when these cardiovascular outcome and kidney disease trials were published. And as you can see, by 2019, as the evidence was accumulating and guidelines were beginning to recommend these agents for heart and kidney protection independent of glycemic lowering, we did see an uptick. But as recently as the first quarter of last year, it's still less than 15% overall. So I want to bring that out because if patients are to receive the benefits of ACEs, ARBs, SGLT2s, or GLP-1s, we really do need to focus on dissemination and implementation because they'll only benefit if they're able to receive the therapies. Now, stumbling on the newer glucose-lowering agents for heart and kidney protection reminds me a bit of this Jackson Pollock painting from 1952 that he titled Convergence. It's beautiful in its own right, but it's really rather non-directional, and we cannot depend on serendipity to keep discovering new agents that are so highly protective of the heart and the kidney, especially when there still remains residual risk. So as I mentioned in the context of the GLP-1s, inflammation and fibrosis is really a very important target. And the previous agents that we've had, such as ACEs or ARBs, lower blood pressure and intraglomerular pressure. SGLT2s and GLP-1s are anti-hyperglycemic agents that have some off-target effects, but we really have not yet had agents that specifically target this most important process that drives a number of the mechanisms of kidney injury, both in the tubular interstitium and the glomerulus, that culminate in progression of CKD and kidney failure. So in this conceptual model from one of our papers, we illustrate the importance of inflammation, and it's particularly important in the tubular interstitial compartment. And as I mentioned, in addition to resident cells such as dendritic cells and myofibroblasts, there also are immune cells that invade the kidney, particularly macrophages and gut-derived T lymphocytes. And it turns out that the mineralocorticoid receptor is actually a very potent pro-inflammatory receptor. So when one of its ligands, aldosterone or cortisol, engages this receptor, it transits to the nucleus where it promotes transcription of a number of inflammatory and fibrotic mediators. This occurs to some extent in the glomerulus in both intrinsic cells such as podocytes and mesangial cells, but importantly in invaders, monocytes that become tissue-based macrophages, and again, importantly in the tubular interstitium, where macrophages and fibroblasts are activated to produce inflammation and fibrosis. And it turns out that these are very profound effects in the kidney, as much or more so than homeostatic regulation of sodium and potassium transport in the distal nephron. So with regard to this target, one of the newest agents is a non-steroidal mineralocorticoid antagonist called Phenerenone. And it turns out that Phenerenone has very high affinity for the mineralocorticoid receptor and has potent effects to block inflammation and fibrosis, but interestingly enough, less effects on electrolyte transport. So we conceptualize this as being an anti-inflammatory therapy and it has lower risk than conventional mineralocorticoid antagonists to produce hyperkalemia because it doesn't have as much effect on electrolyte transport as it does on gene transcription. So that's the background, but importantly in the Fidelio trial, which tested Phenerenone 10 or 20 milligrams versus placebo in type 2 diabetes and CKD on top of an ACE or an ARB, we see a reduced risk of the primary outcome, which was a kidney disease outcome, as well as the secondary cardiovascular outcome. But just last week at the European Society of Cardiology, the companion trial was presented. And this was Figaro, also done in a population with type 2 diabetes and CKD, but most of them had microalbuminuria and preserved GFR, so not as advanced with kidney disease. So in this case, the primary and secondary outcomes were flipped, such that the primary outcome was cardiovascular, and again, significant benefit, almost exactly the same effect size as in Fidelio. And then for the composite kidney disease outcome, which was secondary in Figaro, also a benefit. It has not yet been published, but they also presented Fidelity, which was a meta-analysis of Figaro and Fidelio together. And again, the risk estimates were almost exactly the same together, but there were some 13,000 patients followed for a median of 3 years. CV endpoint hazards ratio is 0.86, so about 14% risk reduction. But note that in the meta-analysis together, the kidney disease endpoint hazards ratio was 0.77, so an even larger reduction in risk, some 23%. Hyperkalemia was more common, with Phenerenone occurring in about 14% versus 7% in placebo, but this was manageable in most of the patients who stayed in the trial. The Cadigo guidelines in nephrology are our international guidelines that are evidence-based. Last year, not quite a year ago, the diabetes and CKD guideline was published based on the SGLT2 inhibitor data. And the main recommendation is represented here as a pyramid that all people with type 2 diabetes and CKD should have, if you will, a base of good risk factor management and healthy lifestyle. And most patients should have either an ACE or an ARB, as well as an SGLT2 inhibitor. And we would now make the case, based on the emerging data from the Phenerenone trials, that an MRA should also be part of this regimen, and that a GLP-1 receptor agonist, even from the standpoint of glucose lowering and cardiovascular risk reduction in this population, is also useful in most patients. And we'll learn from FLOW whether or not it also reduces risk of kidney disease. And although we said some patients, I would argue that most patients also should have antiplatelet therapies to reduce the very high risk of atherosclerotic CVD. And now that we have this menu of therapies, we can think about how we apply them strategically in a patient. So this is just a case of a patient from our center where I think he represents how we personalize now care for type 2 diabetes and atherosclerotic CVD. So he's a 42-year-old indigenous man. He has type 2 diabetes diagnosed at a young age, 15 years, and he was referred to nephrology for advanced CKD. He has the classic full house of risk factors. He's on an ACE inhibitor, calcium channel blocker, statin, metformin, and insulin glargine. His blood pressure is a bit high. He's overweight. And although his GFR is quite low at 23, his potassium is still acceptable. He has macroalbuminuria. He's got an A1C that's high. Lipids is shown here, reasonable but not ideal. And he is known to have coronary calcification based on an incidental finding from a chest CT. So here, for example, based on Award 7, we would pivot to a long-acting GLP-1 receptor agonist, dulaglutide, for glycemic control, but also for cardiovascular risk reduction. Of course, we're going to stop the metformin because his GFR is too low, and we no longer need the insulin glargine because dulaglutide substitutes his basal therapy. We need to get his blood pressure down by intensifying his antihypertensive therapy. We should add aspirin and provide high-intensity statin. And again, as always, counsel about increasing physical activity, nutrition, and weight management. And I would make the case that the GLP-1 will also help with managing weight. So finally, the last class I'll talk about just briefly are the endothelin receptor antagonists. And again, there is biological plausibility across hemodynamic, anti-inflammatory, and direct anti-fibrotic mechanisms in kidney cells. Another approach to more precise phenotyping was conducted in the SONAR trial of Atrocintan. And after patients were stabilized on a renin-angiotensin system inhibitor during the run-in period, all of them were exposed open label to Atrocintan for 6 weeks. And this was to screen for both safety and efficacy. This class had been limited in therapeutic development due to heart failure events. So they screened out people who had more than 3 kilos weight gain or a BNP above 300 picogram per ml because they were deemed to be at risk of developing heart failure and not safe to continue. They measured their efficacy outcome as an early 30% reduction in albuminuria after 6 weeks, but they randomized both the non-responders and responders to Atrocintan. This study was presented and published on exactly the same day as Credence in 2019 at the World Congress of Nephrology. Credence published in the New England Journal and SONAR in Lancet. And even though SONAR has received less attention, note that the hazards ratio is very similar to that in Credence. And interestingly enough, there was no interaction in treatment response between responders and non-responders based on that early reduction in albuminuria. So in terms of precision phenotyping, SONAR delivered in avoiding heart failure events in a high-risk population, but it turned out that early albuminuria reduction was not a good marker of response. So basically, irrespective of the early albuminuria response, all of these individuals benefited. And so this suggests that endothelin may be acting via pathways that aren't necessarily represented in albuminuria reduction. So we need even better risk markers going forward. And the good news is that this is now being resurrected into therapeutic development. And in fact, in SONAR, we had the opportunity to look at the combination of SGLT2 inhibitors with an endothelin receptor antagonist because there was drop-in use. And in fact, in those who received both, there was a reduction in body weight compared to an increase with endothelin antagonism alone. And there was an even greater reduction in albuminuria over time, suggesting more clinical benefit. So with combination therapy, we proposed that not only would we get more therapeutic efficacy in terms of kidney protection, but we could mitigate the risk of applying the endothelin receptor antagonist because the SGLT2 provided some diuretic effect and would protect from the risk of heart failure. So I'll wrap up by saying our standard of care for diabetic kidney disease has been an ACE or an ARB, but unfortunately these agents are underutilized in clinical practice. And this is something we really need to address if we want patients to benefit from the new agents such as SGLT2s, which you'll hear about in the next talk. But GLP-1s and non-steroidal mineralocorticoid antagonists are really poised to also deliver remarkable benefits. And with more precise phenotyping, we now, even with just based on clinical criteria, can improve patient selection for both efficacy and safety of the new agents. So thank you very much.